One login, no second step. U.S. healthcare payments stopped. Change Healthcare legally skipped MFA on infrastructure handling 1/3 of American patient records. Change Healthcare processes 1 in 3 American patient records. Stolen credentials. A Citrix portal with no MFA. The system accepted them. No 0-day, no technical exploit. A username and a password. That was the entire entry mechanism. The company had $371 billion in revenue. They didn't skip MFA because they couldn't afford it. The regulations said they could. That last line is where most coverage stops. A breach happened, a company got hacked, ransomware operators got in. But that framing misses what actually happened here. This is not a story about attackers. It is a story about the architecture that made the attack this easy, and the governance framework that permitted that architecture to exist. Change Healthcare is not a hospital. It is the clearinghouse layer between providers and payers. The infrastructure that processes claims, verifies eligibility, routes payments, and handles billing transactions for hundreds of thousands of physicians, pharmacies, and hospitals across the United States. 15 billion healthcare transactions annually flow through it. 1 in 3 patient records in this country passes through its systems at some point. That concentration is the result of decades of consolidation in healthcare payment infrastructure, and when attackers entered through a single, unprotected portal in February 2024, they did not breach a company, they shut down the payment layer of U.S. healthcare. Within hours of the attack, the consequences were visible across the country. Pharmacies could not process prescriptions. Hospitals could not submit claims. Physicians could not verify insurance coverage. An AHA survey found that nearly 60% of affected hospitals reported losing at least $1 million in daily revenue. Industry estimates put aggregate provider losses well over $1 billion per day during the outage. Small and independent practices, which operate on thin margins, were borrowing money to cover payroll. This was not a data problem. This was an operational collapse. 192.7 million individuals ultimately had their data exposed, more than half the population of the United States. The largest healthcare data breach in recorded history. But the number that matters for understanding how this happened is not 192.7 million. It is one portal, one missing authentication step. Here is what the entry actually looked like. Change Healthcare operated a Citrix remote access portal, enterprise software that allows employees to access internal systems from outside the corporate network. The portal required a username and a password, no second factor. United Health Group CEO Andrew Whitty confirmed in congressional testimony that attackers used compromised credentials to remotely access the Citrix portal, which lacked multi-factor authentication. Security researchers confirmed no known software vulnerability was exploited. No 0-day has been publicly identified in the intrusion path. Entry required stolen text. This breaks the first professional assumption. A breach at this scale, against a company of this size, processing this volume of sensitive data, must have involved something sophisticated. It required stolen text. 2 fields in a login form. However, the mechanism is not the most important part of this story. The harder question is why the mechanism was available. Change Healthcare is a subsidiary of United Health Group. Approximately $371 billion in annual revenue as of 2023, the largest health insurer in the United States by revenue. This is not an organization with resource constraints. So why did the portal not have MFA? The answer is governance architecture. Under the HIPAA Security Rule, the technical safeguards that MFA falls under were classified as addressable rather than hard required, giving covered entities discretion over whether to implement MFA based on their own risk analysis. An organization could assess its environment, determine that MFA was not reasonable or appropriate for a given system, document that determination, and remain in compliance. Change Healthcare made that determination. The governance framework permitted it, and on a remote access portal connected to infrastructure processing 1/3 of U.S. patient records, no second authentication step was required. The addressable classification was not a loophole someone exploited. It was the intended design of the rule. And then UHG reportedly paid the ransom. Security researchers and multiple investigations widely report that approximately $22 million was transferred to an ALPHV Black Cat-linked wallet. Whitty testified in Congress that the decision to pay was among the hardest he made. The data still leaked. Security researchers describe what followed as an exit scam. ALPHV keeping the ransom and dissolving operations, leaving affiliate operators who conducted the actual attack without their share. A second group subsequently claimed to possess the same data, and samples appeared on dark web leak sites, regardless of the payment. The governance failure did not end with the breach. It extended through the response. The Office for Civil Rights at HHS initiated an investigation. OCR's enforcement pattern in ransomware cases has been consistent. Penalties attach not to breach outcomes, but to the adequacy of risk analysis and safeguard documentation that preceded them. In April 2026, OCR announced 4 ransomware-related settlements, totaling $1.165 million. Both cases involved findings of inadequate risk analysis and insufficient safeguard implementation. The enforcement template is already operational, but OCR did not stop at enforcement. The agency used the Change Healthcare breach as the basis for a proposed rewrite of the HIPAA Security Rule. The Notice of Proposed Rulemaking was published in the Federal Register on January 6, 2025. The central change, OCR's proposed rewrite, would make MFA a required safeguard for systems accessing electronic protected health information and remove the addressable flexibility for those technical controls. The rule could be finalized as early as 2026, though exact timing has not been set. But while OCR was rewriting the federal rule, Nebraska's Attorney General was already in court. The Nebraska AG filed suit in December 2024, alleging that Change Healthcare's security failures and delayed notification of affected individuals violated Nebraska consumer protection and data privacy law. Defendants named Change Healthcare, United Health Group, and Optum. Change Healthcare moved to dismiss. Lancaster County District Court denied the motion. The court ruled that Nebraska had sufficiently alleged its claims. The case now proceeds forward, with discovery and production of governance records expected. Nebraska is not alone. Multiple state attorneys general, federal regulators, and class action plaintiff groups are active. The litigation surface is still expanding. This is the 4th reversal embedded in this story. The assumption is that enforcement against a breach of this complexity will take years to materialize. The reality is that a state court has already ruled. The case proceeds, and OCR's April 2026 settlements demonstrate the enforcement architecture is operational now. Change Healthcare is not the lesson. Change Healthcare is the example. The lesson is what this failure pattern reveals about any organization operating critical infrastructure under governance frameworks that permit optional security controls. Infrastructure concentration, combined with governance optionality, is not a healthcare-specific problem. It is a structural condition present in any sector where organizations with concentrated responsibility have been permitted to assess mandatory controls as unnecessary. Every enterprise operator, Running addressable security safeguards is optional, is making the same institutional decision that Change Healthcare made. Every clearinghouse, business associate, or covered entity that has not documented its MFA determination is now inside the regulatory crosshairs. And every organization in any sector running remote access infrastructure without a second authentication factor is carrying the same single point of failure architecture. The compliance enforcement wave is already moving. When OCR's proposed rule is finalized, every covered entity and business associate will need to demonstrate documented MFA deployment and a compliant risk analysis across all systems accessing electronic protected health information. The April 2026 settlements are the template. Penalties were tied to governance record, not breach outcome. An organization that experiences a breach and can demonstrate documented, compliant risk analysis and implemented safeguards is in a materially different enforcement position than one that cannot. The decision lens is direct. Every operator in this ecosystem faces two questions. Has your organization documented its MFA determination for every system accessing sensitive data? Does that documentation reflect a genuine risk analysis that would survive scrutiny in active litigation? Those questions are being asked right now in a Lancaster County courtroom. They will be asked again at scale when OCR's enforcement wave reaches organizations that have not answered them. The Change Healthcare breach was not caused by a sophisticated adversary. It was caused by a governance decision that was legally permissible, institutionally rational under the existing regulatory framework, and catastrophically wrong given the concentration of infrastructure it was protecting. The regulation permitted the decision. The decision permitted the entry. The entry permitted the collapse. That chain is now being closed. Through rulemaking, through enforcement, through litigation, but the closing of that chain does not undo the architecture that exists right now in organizations that have not yet been tested. The source documentation for this episode, OCR materials, the Nebraska AG filings, the NPRM, and the congressional testimony is linked in the description. Everything cited here is on the record. The next episode in this series examines how the same infrastructure concentration and single point of failure architecture appears in a different sector, with a different regulator, a different entry mechanism, and a different set of organizations that believed their governance documentation was sufficient.